So I'll just go on to the first case. It's a 25-year-old female with an endocervical mass. So I think all of you have got the pictures, right? Payal?
Yes, sir.
Okay. So could you please describe, this is the using 2x objective, that is 20x magnification.
Yes, sir.
Can you please describe the lesion as you
So
see it over here?
So section show a mixture of thick-walled blood vessels, bundles of smooth muscle cells, and mature adipose tissue arranged in an interlacing pattern.
Occurring in an infiltrating pattern. Anything else? Thick-walled blood vessels, anything else?
Sir, at one end we can see, sir, the nabothiensis. Most likely, sir, they are nabothiensis.
Nabothian. These are the endocervical glands. Okay, dilated endocervical glands. What about these? Can see the pointer, right?
Yes, sir.
What are these? Simranpreet, can you help? Simranpreet? Okay. Swarnima, can you help?
Sir, epithelial cells? Epithelioid cells? Sorry, sir. Epithelioid cells? Spindle-shaped cells?
Can you make out the spindle-shaped or epithelioid cells over here?
No, sir. It is a low-power view, but it is an encapsulated, circumscribed mass.
It's
Like
a
we can.
circumscribed mass. That's the first thing.
Yes, sir.
Payal described vessels, adipose tissue. She mentioned infiltrating adipose tissue. And she mentioned spindle cells. I think smooth muscle bundles.
Yes.
What are these?
So these are
Okay,
collagenous
I'll
strands.
move to the next 2x view. Swarnima, can you please describe? Can you describe? Okay. See, over here, since the description is not forthcoming, I'll just fibrocollagenous stroma. Good. Someone has mentioned fibrocollagenous stroma. This is a circumscribed mass comprising of 3 elements. First, there are these thick-walled blood vessels. There are plenty of thin-walled blood vessels. These are endothelial cell lining, fine capillaries also. So both thick and thin-walled blood vessels infiltrated by fat, as well as another component which we cannot make out so clearly in the 2x objective view, but on 10x we can make out that these are spindle cells. So they are fascicles and bundles of spindle cells. What are fascicles? Payal, what are fascicles?
Sir, longitudinal arrangement of.
It's not only longitudinal, they seem to crisscross one another, cross one another. Okay. Here, fascicles cross one another. Bundles, they are either on the transverse section or in the longitudinal section, you can get that. So there are fascicles and bundles of spindle-shaped cells. These blood vessels, many of them you can make out their media. In some cases, there seems to be some sort of deposit or some sort of hyaline change, and there is plenty of fat. So, fascicles, bundles, whorls. What do these spindle cells look like? Fine. What do these spindle cells look like?
So they look like the smooth muscle cells.
Smooth muscle. Why are you calling them smooth muscle cells? I'll just move forward to the 40x. Why are you calling them smooth muscle cells?
Sir, because they are having eosinophilic cytoplasm with bland, sir, elongated nuclei.
And someone has mentioned cigar-shaped nuclei. Elongated nuclei, the ends are rounded. There is some amount of collagenization, some amount of hyaline change. Okay? So, to summarize, this is a lesion which comprises of an adipose component, of a vascular component which is both thick-walled and thin-walled, and this has got something, a spindle cell component with cigar-shaped nuclei, seemingly muscular. Any other things, any other causes of spindle cell nuclei you can think of? And they seem to form whorls. Okay. Any other differentials you can think of beside muscles?
Leiomyoma.
Okay. Someone has called angiolipoleiomyoma. Angiolipoleiomyoma is not an entity in WHO, mind you. Angiomyolipoma. Good. There's a combination of it's a well circumscribed tumor, a mixture of adipose tissue, thick and thin walled vessels, fascicles, bundles, and whorls of spindle cells with cigar shaped nuclei. It's well differentiated. One thing you should have mentioned, there were no mitotic figures. They were all bland. So, getting into that, spindle cells, it's a mixture of adipose tissue, thick and thin walled vessels. What are the differential diagnoses you can come out with? It's a seemingly a benign lesion because of bland nuclei, mixture of adipose tissue, thick walled vessels, and spindle shaped cells. Anyone? Okay. One differential diagnosis, lipoleiomyoma. Everyone is thinking of lipoleiomyoma or angiomyolipoma or angiolipoleiomyoma. Okay. None of you thought of myofibroblastoma. Why? Myofibroblastoma, besides they have spindle cells, they have thick-walled blood vessels, they can have an adipocytic component. None of you thought of a cellular angiofibroma. Okay? Again, thick-walled blood vessels, they have a thick-walled blood vessel, they have collagenization, they have fat. All of these can be infiltrated with fat. Angiomyofibroblastoma. Admittedly, there's one lymphomatous variant of angiomyofibroblastoma, which has all three components. There's a lymphomatous component of solitary fibrous tumor. They have all the components, and I can tell you all these four are more common than angiomyolipoma in the cervix, and a rare diagnosis is rarely correct. Okay. So these should have come out first. Angiomyolipoma, of course, is a differential. You have to consider that in the differential. And someone mentioned angiolipoleiomyoma. Well, that's not yet there in the WHO. What is there in the closest cognate in the WHO classification is angioleiomyoma with adipose metaplasia. These are the common differentials of a mixture of adipose tissue, thick-walled vessels, and spindle cells. So, Payal or Ayushi, is Ayushi there? Anyone? Can anyone tell me, so what are the stains and how will we differentiate them? Let's see. You can type it that in also. This is Desmin. Spindle cell lesion. Is Desmin positive or negative? Sonali has said CD34, actin and desmin. Okay, CD34, actin, desmin. So this is positive. Desmin has cytoplasmic positivity. You can make out the cytoplasmic positivity in the spindle cells, not so much in the endothelial cells. That's expected. Someone has mentioned HMB45. Good. So desmin positive. I have put RB1. I'll get into that later. Why? Can anyone interpret RB1? RB, retinoblastoma gene, RB1. What is the interpretation? While
Sir, it is showing nuclear positivity.
it's not, it's RB is a tumor suppressor gene for anyone. A tumor suppressor gene is not classified as positive or negative. It is classified as wild type or mutant. In certain spindle cell lesions, like cellular angiofibroma, okay, and angiomyofibroblastomoma, there is diffuse loss of RB. Now, over here, you see a few nuclei which are positive and a few nuclei which are negative. Okay, so if you get a few nuclei positive, few nuclei negative, that means it is wild type. That is the normal state of a tumor suppressor gene. That is wild type. Okay, it would be mutant if this was diffusely positive, diffuse nuclear positivity, or diffuse loss. And in the case of soft tissue tumors, you would look for loss. This is not loss, this is wild type. Okay, so it's RB1, wild type. Next, H. caldesmon. H. caldesmon stands for the muscles. It is more specific than SMA. Okay, smooth muscle actin. It is more specific than that. What is it? It's positive. It's a cytoplasmic marker, positive. Someone has called it positive. Good. So it's a positive and it has got diffuse, strong positivity. H. caldesmon differentiates between fibroblasts and smooth muscles. Okay. Then ERG instead of CD34, that stains the endothelial cells. For the endothelial cells, are the endothelial cells positive? I think just look at this.
Yes.
Yes, sir.
Yes, sir.
Endothelial cells are positive. So, and we can see that those slit-like spaces were those of endothelial cells. So those are involved vessels and HMB45. There is nothing in HMB45. It is not taken up the stain. I also stained melan. Melan was also negative. So desmin, strong positivity. Okay. H. caldesmon, strong positivity. RB1, wild type. HMB45, negative. ERG, positive for endothelial cells. What is the diagnosis now? What comes out? What do you think? Well, myofibroblastoma. Okay, it should be CD34. It's not CD24. CD34 positive, desmin positive. RB1, there should be loss. RB1 was wild type. So RB1 is, that rules out myofibroblastoma. Cellular angiofibroma. Desmin or SMA is usually absent, even though they may be present in 10% cases. But this is also associated with RB1 loss. Someone has mentioned pleomorphic lipoma over here. Okay, I'll get into that. Pleomorphic lipoma does not explain H. caldesmon positivity. Okay, now angiomyofibroblastomoma. Where are the alternating zones of cellularity? It should have alternating zones of cellularity. It's not there. And that is H. caldesmon negative. Angiomyofibroblastomoma is ruled out. solitary fibrous tumor because of the small fine vessels, I thought, but that should be Desmin negative. Okay, that has a staghorn pattern of vasculature. Angiomyolipoma, someone had put that down over there. That is HMB45 positive in 90% of cases, or Melania positive. Both were negative in this case. So what is left is angioliomyoma with adipose metaplasia. Please realize it is positive for Eschal-Desmond, positive for Desmin. It has got thick-walled blood vessels, and that shows hyaline change in the vessels. And there's quite often adipose metaplasia over here. So, final diagnosis over here is angioliomyoma with adipose metaplasia. But please realize this, the most important part is to get your differentials. For spindle cell lesions, you cannot come to a single diagnosis so easily. You need the differentials, and many times, once you put the differentials, you should be knowing how to get into the discussion with the differentials. The final diagnosis is, the examiners, what they expect is that you know the logic, how you make the diagnosis. You treat it as a benign lesion because of the well circumscription. The fat is not infiltrating. That is the important thing to differentiate from benign lesions. You look for mitotic figures. You see the thick-walled blood vessels, the fat. You see that these are the combination of these three, and you know all the various differential diagnosis, and you know how to work up the case. Okay, so that's that. Anyone? Any questions over here? See any questions? Any questions over here? Nothing.
No, sir.
Okay.
You can start second.
Okay. So I'm not going into this. I'm not getting into the second thing. I just want to say put a few things about angioliomyoma. Angioliomyoma is not classified along with leiomyomas in the WHO book. It is classified along with myofibromas, with angiopericytomas. It's an angiopericytoma-like tumor. It's a well circumscribed tumor consisting of planned smooth muscle cells as well as concentric growth around vascular channels, which was present over here. There are three types: solid, venous, and cavernous. The solid, there is thick-walled smooth muscle cells, okay, with intervening thin-walled slit-like vascular channels. The venous type had thick muscle-coated blood vessels along with intervascular smooth muscle bundles. Cavernous type has got large cavernous type of veins. Some of these have myopericytoma-like features, but myopericytomas are negative for Desmin. And both myopericytomas as well as angioliomyomas, they have concentric perivascular proliferation of myoid cells. So these are the things about angioliomyomas, and you can get this in the WHO 5th edition easily. These I've taken almost entirely from there. So, case 2 was a 50-year-old male, urinary bladder mass. Okay. I brought the 10x view. Anyone volunteers to describe? Royana?
Sir, these are the section examined shows tumor cells arranged in the form of nest tubules as well as lying discretely. They show moderate pleomorphism in the form of high nuclear to cytoplasmic ratio.
Okay. Right. I won't agree or disagree. right now. The next case is over here. Anyone else want to describe? Hello? Yes? Infiltrative. Good. This tumor is infiltrating into the underlying tissue and infiltrating in the form of trabeculae, cords, okay? Not so much nests. Papillary is less common over here. I am not finding the papillae over here. The papillae, these are just infiltrating bundles coming in from the top. I can see the septae, something like a septae, but I'm not sure about the papilla formation over here. The papilla formation is, there is some papillary formation comes out over here. Someone has called, looks like neuroendocrine. I'm going to ask, it was Gayatri, I'm going to ask her why. Okay, 10x. On 20x, there are these things, there are mitotic figures present. Someone has pointed out mitotic figures over here. Someone said pleomorphic nuclei. Anyone else wants to put anything? Someone said looks like neuroendocrine. Why? Why does it look like a neuroendocrine?
Chromatin.
Chromatin. I want to say that because of the chromatin, but there are certain. Okay, can you please show infiltrated? Here, the cords coming in. I went back. This is the stroma. It's showing fibrosis, dysplasia. Someone said discohesive cells, even though discohesive cells are more of a cytology description. Okay. So here are the cords, trabeculae. Okay. Someone has mentioned nuclear molding. Okay. I'm not so sure there are nuclear molding over here. I have gone into the high power since nuclear molding went into this. And someone mentioned this neuroendocrine features. I've gone into the 40x. Someone mentioned high NC ratio. There are prominent nucleoli. Okay, good. There are cells with prominent nucleoli. There is pleomorphism. There is this. What is this? This looks like a mitotic figure, an atypical mitosis. There's another mitotic figure over here. Okay, there are prominent nucleoli. And in some cases, there is, of course, it shows a speckled chromatin, vesicular chromatin, speckled, vesicular chromatin is also there, as well as speckled chromatin is there. Someone has mentioned urothelial carcinoma. Okay, mitosis and nucleoli seen. So, another high power, there's quite a bit of pleomorphism. Okay, so the description is tumor with cells arranged in trabeculae, cords and sheets, infiltrating into stroma. Cells have moderate amounts of eosinophilic to amphiphilic granular cytoplasm. The nuclei, poorly differentiated carcinoma likely urothelial. Nuclei show nucleomegaly and isocytosis, prominent nucleoli. Even at 10x, the nucleoli was seen. And they have coarse chromatin as well as fine chromatin. So I have got two differentials. Someone has said neuroendocrine. Someone has said urothelial. Okay. Are the others able to see properly? Katyayani, are you able to see this now? Katyayani?
Yes, yes, so we are able to see all the slides.
Okay.
So whoever is not able to see, they can re-log in so they can, if there's some internet issue, I hope it gets resolved and they can see the slides clearly.
Is it clear? Can I make up the chromatin over here? Someone has said
Yes.
NET grade 2-3. Neuroendocrine tumor grade 2-3. Okay. So the differentials, large cell neuroendocrine. Someone has said urothelial, poorly differentiated. No. So there's urothelial carcinoma. Okay. Good. There is neuroendocrine carcinoma. Both I have considered instead of NET. See, why should you say NET? NET is neuroendocrine tumor. Amongst the neuroendocrine tumors, you are seeing clearly, you are seeing the infiltration. Okay, so the differential diagnosis should be neuroendocrine carcinoma, especially large cell neuroendocrine carcinoma. That should be your differential. Now, over here, this is, we have done cytokeratin 20. Now, is cytokeratin 20 positive or negative? What is it? Can anyone say? Should cytokeratin 20 be positive in urothelial carcinoma? Okay, Khushi has mentioned that as focal. What does Roina think?
Yes, sir, it is focally positive.
Focal positive. Someone has called it negative in tumor cells. Look at the nuclei. The nuclei are as large as the other cells over here. This is given at 20x. Focally positive. There are areas where it is negative. Okay, cytokeratin 20 is positive. So that favors a urothelial carcinoma or a neuroendocrine carcinoma, large cell. Okay. CK20 does not go for NET. CK20 goes for urothelial carcinoma. Merkel cell carcinoma, METs. I'm not going to get into such a rare differential right now. Urothelial carcinoma. But these are negative out here. Now let's see. This is INSM1. INSM1 is a neuroendocrine marker. It is nuclear. It shows nuclear positivity often. This. Okay, INSM1, is this positive? INSM1 is also positive. So now, INSM1 is positive. What about these cells? There are negative INSM1 cells also. So you see CK20 positive in a few cells, negative in a few cells. INSM1 positive in a few cells, negative in a few cells. So what should be the diagnosis? Anyone coming out? What is MINEN? Mixed tumor. Someone has just said mixed tumor. Good. Diagnosis is mixed. Large cell neuroendocrine. Why large cell neuroendocrine? Because there was cytoplasm. With small cell neuroendocrine tumors, you don't get so much cytoplasm. So there's mixed large cell neuroendocrine and urothelial carcinoma. You have to realize one thing. Small cell carcinomas have that neuroendocrine chromatin. Large cell carcinomas may show nucleoli, they may show anisocytosis, they may show nucleomegaly. Okay? Both of these components are positive, but they also show large negative components. Please, why is this important? This is important. A mixed cell tumor, calling it mixed instead of a pure neuroendocrine. Just don't call it neuroendocrine if you get it and be satisfied with that, because the treatment of pure neuroendocrine carcinoma and mixed tumors, they are different. For pure neuroendocrine tumors, the main treatment is platinum-based chemotherapy. It's platinum-based therapy over here. The local surgical options are for local control, but that's a secondary component. Once it's a mixed tumor, cystectomy becomes a first-line treatment over here. That becomes very, very important. The treatment differs. The philosophy of treatment differs. So just getting INSM positive or synaptophysin positive, don't call it a neuroendocrine carcinoma straight off. Most bladder neuroendocrine tumors are mixed tumors. Okay? So I am going into the neuroendocrine tumors of the urinary tract. So for this, there are three main things. One is well-differentiated neuroendocrine tumor. These are bland cells. There is no nuclear pleomorphism over here. They show the characteristic speckled neuroendocrine chromatin, but low mitotic activity. Small cell neuroendocrine carcinoma, there are relatively small cells. It's greater than 3 lymphocyte diameter, high NC ratio. That means cytoplasm will be less. Okay? And nuclear molding is frequently present in this type. Not so much in the large cell neuroendocrine type. This did not have so much molding. So the person who called molding, okay, see the slides again. The molding is a very, very minor component over here. Molding is more common in the small cell neuroendocrine carcinoma. And the characteristic speckled or salt and pepper chromatin is found over here. Salt and pepper chromatin is not the primary feature. They are seen, but with small cell neuroendocrine carcinoma, you may not find any nucleoli. Prominent nucleoli, high-grade nuclei, frequent nucleoli, they are a feature of large cell neuroendocrine carcinoma. They have cytoplasm, eosinophilic cytoplasm. They are arranged in nests, acini, and trabeculae. That has been mentioned as features of a neuroendocrine carcinoma, this architecture of nests, acini, and trabeculae. Once you find that with less number of papillary formations, please consider neuroendocrine in the differentials and know how to follow this up. Okay? Neuroendocrine tumors, there are neuroendocrine rests in the bladder. Many of them arise from them. The well-differentiated neuroendocrine tumors arise from nests, especially near the lamina propria. But they do not cross the lamina propria. That's why, since it does not infiltrate, that is called a well-differentiated neuroendocrine tumor. They do not infiltrate. So, any questions? I'll just move on to the...
One question is there, so what may be the histogenesis of these mixed tumors?
Histogenesis of mixed tumor. Okay. Histogenesis of mixed tumor is usually from aberrant differentiation. All urothelial and even prostate, the adenocarcinoma cells, they have an aberrant differentiation towards the neuroendocrine type. In the prostate, it's more common. It is not a dual differentiation. At least the studies have shown that both the components are monoclonal in origin. They are arising from the transitional, cells undergoing transitional differentiation. All cells, all tumor cells, all carcinomas arise from stem cells. If there is dual differentiation, one towards the transitional or urothelial cells, along with neuroendocrine features, you get the mixed tumors. That was one of the things. However, mostly as it is, all the research is ongoing over there. Okay?
Yes, sir.
And of course, mixed tumors, they are the commonest amongst the bladder.
Okay, thank you, sir. So no more question for now.
Okay, thank you. Am I going too fast? Dr. Kajal? Am I going too fast?
No, sir.
I think, sir, it's comfortable pace.
Comfortable pace. Okay. Thank you. Okay, so this was a breast lump, 40-year-old female. This is the 4x objective view, that is 40x magnification, what we call as the common scanner view. So can anyone describe it? You can type it in, or Payal or Simranpreet or Swarnima or Ayushi, they can also say that. You are welcome to speak out. Anyone? I just give a few seconds over here.
Small breast ductular lobular architecture is lost. We can see hemorrhage and some necrosis.
You see necrosis over here. Sheets of what cells?
And
Are they stromal or epithelial?
and sir,
You cannot make out. This is not hemorrhage. This is a dilated blood vessel. Okay.
okay, sir.
There is
Yes, sir.
necrosis. Let's see again. 4x view, but the nuclei seem larger over here. Some of the nuclei seem quite large. Please note there's dilated vessels, there's necrosis, and there are these cells, coagulative necrosis, very good. And they are stromal cells, but there are also these cells which have got a clear cytoplasm.
Signet.
Someone has called it myoepithelial cells. Okay, okay, we'll get into that later. Okay, so it's a sheet. Do you find any epithelial cells? Swarnima, any epithelial cells? Anyone else? Any epithelial cells do you see? No, there are no epithelial cells over here. Again, in a non-necrotic focus, same, it's just at 4x, you see mainly spindle cells and some of these cells with clear cytoplasm in the middle. There are certain vessels you see alternating, you can make out. This is more cellular, this is less cellular. Okay, so there are foci of high cellularity in the sections. Let's get into the 40x thing. Anyone will be able to say this. Anyone. They can speak out or they can just type it in. How do you describe the high power? There is clear cytoplasm. Okay, there are cells having clear cytoplasm. What is this? What is this?
Mitosis.
Mitosis. So, how many mitoses did you count in this? This is one single field. 1, 2, 3, 4, 5. I count 5 at least over here. Then there are spindle cells or spindle-shaped cells. Okay. Good. Mitosis. And 5 mitosis in a single field. There are spindle-shaped cells. Some of them have got a clear-cut spindle-shaped appearance. Some of them are more plump. Okay. Some of them almost are rounded. So that's pleomorphism. Someone has already given a diagnosis of malignant pilotes over here. There are these clear cytoplasm cells. What are they? These cells with clear cytoplasm?
Stromal.
Stromal cells. Well, I'll come into the differential over here. Someone has called it borderline pilotes. Someone has called it just pilotes. Okay. This cell around here, what is it? Clear cytoplasm. Look at the nuclei. Myoepithelial cells. So with myoepithelial cells, you want to call it pilotes. Just, what is this cell? Clear cytoplasm. Lipoblast. Good. There are quite a few cells with this clear cytoplasm, and this looks like a lipoblast. And there are these spindle cells. Since the shape and size are different, there is pleomorphism. So there's mitosis, very few epithelial cells, epithelial appearing cells. Okay, pleomorphism, one lipoblast, some amount of clear cytoplasm, alternating areas of high cellularity. And I got a few diagnoses of pilotes over here, malignant pilotes. Okay. The sheets of spindle cells. So, description. Tumor consisting of, someone has called it secretory carcinoma.
So what
Okay,
about
but in that case, they should be present in ducts. Someone has called it metaplastic carcinoma. Good. So, tumor consisting of sheets of spindle cells with high mitotic activity, nuclear pleomorphism. We did not find any epithelial element no clear epithelial element over here. The spindle cells are interspersed with cells with vacuolated cytoplasm, and we found lipoblasts. So, this in mind, the differential diagnosis already got malignant phyllodes, metaplastic. So now, after this, someone has called heterologous liposarcomatous component. Okay, good. That means you are also calling it phyllodes. This is pan-CK. Now, is pan-CK positive or negative over here? See this. Okay. I have got another slide of pan-CK. Gayatri has called it negative. This, Gayatri, is this positive or negative? Pan-CK is cytoplasmic. Yes, this is positive. These are positive cells. 1, 2, 3. Focal positive. Okay, 4, 5, 6. Nivedita has already called it metaplastic carcinoma. Let's see. So that is pan-CK. Now P63. Someone called that these are myepithelial cells. Well, most of them are not. But what is this? P63 has nuclear positivity. What are these? So is it positive or negative? P63? Sonali has called it positive. Positive. Is it more than 1%? The usual definition is 1%, right? Focal positive. So right now, I've given you P63 positive. No, I have done CK56. Cytokeratin 5,6. That's a high molecular weight cytokeratin, right? Is it positive or negative? I've just given a 10x view. Is this positive or negative? Negative. I don't see any. I went into a lower power view just to show this. Negative. Good. So, cytokeratin, pan-CK, focal positive. P63 even less of a focal positive. Cytokeratin 5,6 negative. What is the diagnosis? Now, there are many people who call it phyllodes. Are they still going to call it phyllodes? Think. Or are they going to call it metaplastic carcinoma? Ananta Narayan, metaplastic carcinoma, metaplastic carcinoma. Okay, Ayushi? Maithili, metaplastic carcinoma. Anyone still sticks with phyllodes? Malignant phyllodes? Anyone still sticks with malignant phyllodes? Okay. See, there are malignant phyllodes. Why? The person who called it malignant phyllodes, why? Focal, Gayatri has said, focal positivity can there be in phyllodes. So what's the diagnosis then? Gayatri or Siom, what's the diagnosis? The truth is, there may be focal P63 positivity in phyllodes. There may be focal pan-CK positivity in malignant phyllodes. In malignant phyllodes especially. Both in malignant phyllodes, not in borderline or benign, mind you. In borderline phyllodes. In malignant phyllodes. The truth is, with a small amount of positivity, we cannot really say So malignant fluids with heterologous elements, we cannot really say whether it is still metaplastic or malignant fluids. Heterologous elements, there are plenty of similarities between malignant fluids and metaplastic carcinoma. Both may be spindle cell predominant. Both may have heterologous mesenchymal elements, mind you. So Gayatri was saying heterologous mesenchymal elements, there's a special subtype of metaplastic carcinoma, okay, which is known as metaplastic carcinoma with heterologous mesenchymal differentiation. Okay. Now, lipomatous component is the most common heterologous element in Pilot's tumor. Okay. Both may be spindle cell predominant. Malignant pilotes may have focal P63 as well as cytokeratin positivity. The definition of metaplastic carcinoma that needs unequivocal evidence of squamous cells, fibromatosis-like cells or mesenchymal cells with expression of high molecular weight cytokeratin and or P63 with, there is one thing, focal P63 may be present in malignant Pilot's tumor. So you really, in this case, what you should be doing is, you should be giving both the differentials, wait for with such a low amount of positivity and ask for a total excision biopsy. In the excision biopsy, if the amount is still so low, okay, you may go for malignant pilotes. But there's a high possibility of this being metaplastic carcinoma, having more metaplastic or more cytokeratin-rich areas in the excision. You should not commit. With such possibility, you should not commit for metaplastic carcinoma or pilotes. Give both the differential diagnosis and wait for the discussion. Okay, that's not giving a differential diagnosis is not a sign of weakness. Okay, for malignant pilotes, please know this, that these are the main features: stromal overgrowth under the 4x objective, not under the 10x objective. But in core needle biopsy, you may not often have sufficient tissue. You may have, you may just be able to get, say, no epithelial element at 10x, but in that case, that is known as stromal expansion. Okay, that's a suggestive but not a total hard feature for malignancy. Then nuclear pleomorphism, high cellularity. Yes, okay, metaplastic carcinoma will show a possibility for basal cytokeratins. I mean, around 60 to 70% will show. Okay, high mitotic count. Okay, greater than 10 mitosis per 10 high power field. Using the normal Olympus microscopes we have, they have got a diameter of around 0.5 millimeter, the high power. So greater than 10 mitosis per 10 high power field. And malignant heterologous elements may be present. In case only well-differentiated liposarcoma or atypical lipomatous features are present, that lipoblasts may even be found in borderline Pilot's tumors. Don't make a diagnosis of malignant Pilot's just on the basis of a lipoblast. You need to have other malignant features, other elements. In that case, you can make it, but not on the basis of just a lipoblast. But that is a feature that it's a Pilots that goes in favor of Pilots, not necessarily malignancy. For chondromatous elements, muscular elements, osseous elements, those are more hard signs of malignancy over there. Okay, and if all the features are not present, just a few features are present along with expansion or infiltration into surrounding tissue. If a few features are not present and a few features are present, then you call it borderline. For metaplastic carcinoma, you have to know that metaplastic carcinoma has got plenty of subtypes. It does not have a single morphology. We dealt with possibly a differential diagnosis of spindle cell carcinoma over here, or spindle cell carcinoma, metaplastic carcinoma with heterologous mesenchymal elements. These two are the differentials in our case. But There are other patterns of metaplastic carcinoma also. Low-grade adenosquamous, fibromatosis-like, where that's really well differentiated with wavy nuclei, squamous cell carcinoma arising in the breast, and mixed metaplastic carcinoma, which has got any of a combination of any of anything. Now, Jitendra has written what to write about IHC. You write down the description that this is a spindle cell tumor which shows stromal expansion, okay, shows nuclear pleomorphism, high mitotic rate, just in one field we got 5, high mitotic rate greater than 10 per 10 high power field with presence of necrosis. The differential diagnosis are malignant Phyllodes tumor and metaplastic carcinoma. Don't commit to a single diagnosis. Making differentials is not a sin. Okay? And without IHC, you cannot do it. So, any questions over here?
Yes, sir.
Any more questions?
Yes, sir. One have the question: how to differentiate lipoblasts from normal adipocyte?
How to differentiate? Okay.
Lipoblast.
From normal adipocytes. Normal adipocytes don't have the large nuclei. They don't have those the edges going in and the nuclei actually extending like spiders' legs onto the into the surrounding tissue. I'll just get into this. You see this extending in over here. There was another thing. So normal adipocytes, they will have a signature nuclei. This does not have the signature nuclei. You see, this is what a more, okay, it's not normal exactly because the nuclei is still large, but something like this. You see this larger going in irregularly shaped nuclei. That's how you will get to know a lipoblast.
Okay, sir.
My teachers used to talk of spiders' legs from the nuclei coming in into the cytoplasm, along with the vacuolated cytoplasm. Okay, someone asked some question about cytokeratin 5/6. I think it was
Yes.
Khushi. Was it?
Yes, sir. Yes, sir. She asked the CK5 and 6 is negative. In this case, can metaplastic carcinoma can be ruled out?
No, it cannot, because cytokeratin 5/6 is present just in 60% of cases. So it cannot be ruled out. 40% of cases don't have cytokeratin 5/6. You cannot rule that out. P63 is focally positive. When cytokeratin is focally positive, once P63 is focally positive, how can you rule it out? The very definition of metaplastic carcinoma is presence of high molecular weight cytokeratin and slash or this P63. So we cannot rule out metaplastic carcinoma over here. The aim of this thing is why I gave this case. Again, the final diagnosis is malignant Phyllodes. No, it's not. You cannot say. I gave this case just to show that even with the help of all the IHCs, in many cases, you cannot find a differential, you cannot find a single diagnosis. In those cases, you have to give the differential and wait and know enough to get into the discussion. That is not a discredit over here. The final diagnosis is not malignant Phyllodes. It is likely to be malignant Phyllodes. But over here, this should be reported as, I mean, if someone is reporting it, is final report will follow an excision. You cannot differentiate between malignant Phyllodes and metaplastic carcinoma on this case. Okay, so don't think of a single diagnosis. Is that okay?
Yes, sir.
Okay. Now, I'll proceed on to the case 4. It was a 45-year-old female with a breast lump. So this is the view under the 2x objective. Can anyone describe it? Anyone? I'll be waiting for a few seconds and then I'll proceed. If there is nothing, then I'll proceed. Payal or Simranpreet or Swarnima, you can describe it also if you want. Calcification. Calcification is not the main feature.
Comedonecrosis.
Comedonecrosis is also not the main feature. How do you describe it? Description is one of
neoplasm.
the main parts in for an exam. What do you actually see?
The section
Lobulated.
shows neoplasm of composed of tumor cells arranged in nests and solid islands.
First thing, it is comprised of dilated ductolobular units. Dilated lobular units. Dilated lobular units or dilated ducts and lobules, okay, having epithelial cells as well as necrotic debris, necrotic material. Looks like comedonecrosis. We'll get into that later. And what are these specks? Calcifications. Someone has already called it high-grade DCIS with comedonecrosis. There are few things you have missed. What are these? Okay, I'll just point this out. What is this? Many of the lobular elements, someone has called it invasive ductal carcinoma NST. Okay. Someone has called it, there are tumor cells in stroma. Okay, let's get to the high power. Inflammatory cell infiltrate, lymphocytic infiltrate. These may be lymphocytes. Okay, now, or inflammatory cells. So we are getting to the high power. And there is fibrosis. So there is fibrosis. There are these sharp cells. We are going to see the nature later. And there are, most importantly, distended lobules and ducts filled with epithelial cells, necrosis, and calcifications. Now, at 10x, I have just focused on 10x. Those small things that I pointed at, those were lymphocytes over here. There's plenty of lymphocytic infiltration. There's plenty of fibrosis around here. Just check it out. There's plenty of fibrosis. Plenty of fibrosis. There are lymphocytes. And these are the distended lobules. Anyone sees anything else?
Mitosis.
Okay. I'll just get into the next thing. Anyone sees anything else? What are these? What are these? I have to help you. I have just put to one estimate of the distance. Okay. How much 1 millimeter looks like. Okay. That may be also taken as a clue. Giant cells. Giant cells. Giant cells. So these are also giant cells. Okay. I'll just get into 10x of the distended lobules. There are these and calcification. We don't see any myepithelial cells inside the cells, but we do see myepithelial cells at the periphery, these spindle-shaped cells. Spindle-shaped cells at the periphery, myepithelial cells, but inside I don't see much of myepithelial cells. We do see the central necrosis, which is a comedonecrosis, of course, many people have told it. This ductal element along with this. Do any one of you see any other thing over here? Anything else? Okay, I'll proceed. Okay, there are these. What are these cells, by the way? These cells that I'm pointing at? Look at these cells over here. Look at this cell engulfing this cell. These cells.
Temperable.
Histiocytes. Okay. Rosidooplan. Histiocytes. Now we have gone to the hyper, quite a pleomorphic. The nuclei, they show irregular edges. They show difference in size. Okay, there are mitotic figures around here. Mitotic figures. Just look at these. There's quite a bit difference. So it's a high grade DCIS or grade 3 DCIS over here. These are parts of a grade 3 DCIS. Now, you remember one of the things I showed? I think you were calling this a giant cell. Okay. What is this? What is this? Anyone? Someone has called it microinvasion. What is this? Stroma infiltrated by tumor cells. Okay. And I had already shown one size. Someone has called it microinvasion. So let's get into the description. There are multiple distended ducts and lobules filled or lined by myepithelial cells. They do show comedonecrosis and calcifications. Cells have a high nuclear grade and show increased mitotic activity. All of you agree with this?
Yes, sir.
Okay. Occasional areas of singly scattered or small groups of cells and stroma. Now, this area, all of them are lesser than 1 millimeter in size, seemingly. There's dense periductal infiltrate of lymphocytes, and there is periductal fibrosis. So, now I want to know, I have called it lined by myepithelial cells, but again, humans may be wrong. What are the differentials? What are the differentials now? Come on, I have got one microinvasive carcinoma. I've got one DCIS. Anything else? Anything else in the differentials? You can do it. Fire?
Yes, sir.
Differential bolo. Tell me the differential. LCIS lobular carcinoma. Comedo-like carcinoma. Comedo-like carcinoma, is that invasive comedo-like carcinoma? Siom? I don't know your full name. Is that DCIS or invasive? IDC, infiltrating ductal carcinoma.
Sir, atypical duct.
Okay. First thing.
Atypical ductal hyperplasia.
Okay, invasive. So, of course, microinvasive carcinoma with extensive DCIS. That's a differential because we are seeing those distended lobules, which we think to be lined by myepithelial cells. And we find one focus less than 1 mm. That is why I gave that quite a few foci actually. I have given more than one foci. Microinvasive carcinoma is one of the differentials. Of course. Please remember that there are quite a few invasive carcinomas which mimic DCIS. And in those cases, you cannot know whether those are invasive or not without applying IHC. So, whether each and every distended lobule was an invasive carcinoma or not, you cannot know without doing IHC. So, that is a differential. Okay? And Just DCI is high grade. Many people thought that there was giant cells. What if they are? Some people thought that they were histiocytes. What if it's just DCI is high grade? So how will we get to know? Let's see, I'll just give you the IHC features over there. This is calponin. Calponin is a marker for myepithelial cells. The other markers, P63, CD10. With this calponin, along with this, are all the distended lobules, and this is the representative picture. What is MHC, my dear Gayatri? What is MHC? Anyway, till the time you type that, I'll just go over there. All of them, and this is a representative picture. So right now, so all the distended lobules, there are no myepithelial cells in the center. It's full of epithelial cells, which we showed to be high grade. There is comedonecrosis, and there is total lining. So these invasive lobules are not invasive carcinomas mimicking DCIs. They are actually DCIs. So there is extensive ductal carcinoma in situ over there. Now, I have also used pan-CK. And pan-CK outside the ducts, smooth muscle, myosin, heavy chain. Okay. Anyway, these are the things. So these are pan-CK positive. So they are epithelial cells. Epithelial cells in the stroma with this lymphocytic infiltrate just by the side, dense lymphocytic infiltrate by the side, an immune infiltrate, and the epithelial cells in the stroma. Okay, and they are singly scattered also. So it's not bound by any my epithelial cells over here. So, and I have measured the size earlier. That was just around 1 mm. This is easier to measure from this end, this stained cell to this, around 0.8 mm, not 1. It's less than 1 mm, 0.8 mm. Top to bottom, it is 0.7 mm around. Okay. So these are the things you can see that these are not normal. These nuclei have quite a large size, and they are infiltrating. It's a single cord and single cells scattered inside. Okay, there are other foci of such epithelial cells also. Okay, less than 1 mm in size. So DCIS with microinvasion. That is also known as microinvasive carcinoma. Mind you, DCIS with microinvasion is called microinvasive carcinoma. But there are multiple foci. There are multiple foci of such epithelial cells. Such epithelial cells in the stroma, they are suggestive of invasion. So there is DCIS, there is invasion. So there is DCIS with invasion, with microinvasion. But is it microinvasive or invasive? What is microinvasive carcinoma? Now, this is a case of microinvasive carcinoma with extensive DCIS. Please realize that microinvasive carcinoma may have more than one invasive component, but you don't add the things. If there are 3 or 4 invasive components over there, invasive foci, each measuring less than 1 mm or 1.0 mm, at maximum 1 mm, they are still called microinvasive. They are not added up. However, if anything, any focus just exceeds 1 mm, 1.0 mm, automatically the entire size is upgraded to 2 mm. At that time, it no longer remains a microinvasive carcinoma. It becomes an invasive, I mean, just invasive ductal carcinoma, NST, IDC, or an invasive carcinoma, NST, and stage 1A, T1A, less than 5 mm. So please realize this. anything which is more than 1.0 mm, even if that is 1.1 mm, automatically you have to write the size as 2 mm. That's no longer 1 mm. More than 2 mm, you report to the nearest millimeter. Between 1 to 2 mm, you just correct it upwards. You correct the size of the tumor from 1.1 to 2, 1.2 to 2, and till 1 mm, you measure the size 0.8 mm, 0.9 mm, and call it microinvasive. So this is this. Any questions over here?
No, sir, no questions.
Okay. The main thing is greater than 1 mm small invasive carcinoma, or it is invasive carcinoma. Invasive carcinoma, you cannot get that. Invasive carcinoma NST, this. Yes, we have to take multiple serial sections. We have to take multiple serial sections. And you have to measure that also. And you have to get the slide micrometer rate also. So that's the thing. You should be taking multiple sections in order to, you should try to disprove it is less than 1 mm. You just cannot take one section and say this is a microinvasive focus. What if there's a larger focus underneath? You have to take multiple sections over there. Okay, and that is in response to the question someone asked over here, Antanaran I think asked, you have to take multiple sections. You have to take multiple sections. You have to, and the thing is, there are 2 points I wanted to put forward. There may be microinvasion, there may be multiple foci of microinvasion. Still, they are just called microinvasive. You don't add up the microinvasive foci, but once it goes up or exceeds 1 millimeter, any focus, you just call that it's a 2 mm tumor and report it as invasive carcinoma. Okay. The third point is, even with DCIS, if it looks like DCIS, calpunin is always advisable because there are many invasive carcinomas which mimic DCIS and they have comedo-like necrosis. Someone had already pointed that out. I think it was Gayatri. Thank you. I'll move forward to the next case. Case 5, 48-year female, dysmenorrhea and vaginal discharge with sections from endocervix. Oh, poor Prashant. I think I'm eating into his time. Okay. So, before going into this, this is the superficial section. First section, this is from 2x. This is the superficial section from the endocervix. This is near the surface of the endocervix, this entire thing. Okay, and define these dilated glands over here. Got it? Can anyone describe these? I'll just get into the next 2x features. This is near the surface. Depth right to go deeper. Okay. This is the next deep section. This is no longer at the surface. I have gone deeper over here. It's no longer at the surface of the endocervix, and this is deeper. So these are the sections at 2x. Can anyone just say or describe the glands? Or Payal,
Yes,
can
sir.
you describe the glands? Or sorry, describe the morphology.
Sir, the sections show multiple cystically dilated endocervical glands. They are mostly, sir, they are well formed, elongated, and are lined by basally placed uniform nuclei. And
Okay.
sir, intervening, we can see fibromuscular stroma.
Fibromuscular stroma. Either muscle or fibromuscular stroma. Okay. Muscle or fibromuscular stroma. And what are these blood vessels? Okay. Are they well-formed muscles or fibrous? Are these glands, are they well-rounded?
Angulated.
Where is the
Serrated.
angulated? I'm still seeing it
Angulated.
rounded over here. Mostly rounded.
Serrated glands.
Okay. And these things, thick-walled blood vessels. There are thick-walled blood vessels over here. Very good. And there are glands out here. Let's see this near the superficial layers. Are these glands? Can you describe the nuclei? Are the nuclei well formed? Or the cells? Are the cells? Do they look malignant? Do they look benign? Do they look atypical? Anyone?
So they mostly look benign.
They look benign. Okay. Someone has called it endometriosis. Benign. Right. Well-maintained polarity. There is muscle over here. These glands, do they look, someone is continuously, I'm continuously calling it minimally invasive adenocarcinoma. You have to tell me why. Please also write why. There are these glands. And these are, what are these? These are muscle bundles, not, this is a clear-cut muscle bundle. Okay. You see, there are thick-walled blood vessels, clear-cut muscle bundles. These are glands. Now, again, I'm asking you, are the glands looking benign or malignant?
Benign.
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 Now, this is the 40x view. Rounded architecture. Okay. Get into another 40x view. You say that this is malignant. Well, this is the same glands over here. These, they look benign or malignant? These. Okay. Malignant, Anatha Narayan, benign. What are your diagnoses? Now, I have showed you everything. There was well-formed glands, most of you whom you called benign. Now, at high power, you are calling it malignant. That's because, possibly because it's high power. I'll get into the low power again. Okay, well-differentiated malignant glands. Okay, many of you are calling it benign. Malignant, well-differentiated glands. Why are you calling it malignant, by the way? There's plenty of cytoplasm. The cells are rounded. These are endocervical cells, mind you. Endocervical cells, if they're rounded, that's benign. That's a benign appearance, usually, unless they are very large and they have a high NC ratio. There's quite a bit of cytoplasm on the top. Quite a bit of cytoplasm on the top. There is some amount of anisocytosis over here, but that may be due to cutting. Okay. Anything else that you see over here in this field? Occasional mitosis. Okay, but glands invading smooth muscles, atypical cells. Hyperchromasia, that is because it's a high power. At a high power, you will be calling many things hyperchromatic. Okay. Stratification. Good. Some amount of stratification. Stratification in endocervical cells, they are highly suspicious. There is no stratification over here. Are they benign or malignant? These glands, are they benign or malignant? Are these glands benign or malignant? Anyone? Sion? Benign, malignant. Now, I'll just ask you one question. What are these glands, benign glands? Benign, benign, benign. Good. What are these benign glands doing so deep, okay, and impinging into these muscles? Is it the nature of benign glands to impinge into, just get into, be in the center of muscles, be in between, be amidst muscles, amidst the smooth muscles? What's it doing within the muscles? And then there are these cells, slightly larger and smaller. So, what are your, let's get into the description which we done, by which we are done. They are cystically dilated glands and angulated glands, lined by a single layer of mature appearing glandular epithelium. The cytoplasm of the glandular epithelium are clear or eosinophilic. It should be cytoplasm. Sorry for missing that out. Glands are haphazardly arranged. Okay, check it out over here. You don't see a clear arrangement over here. They're haphazardly arranged over here. Okay? See these glands, they're haphazardly arranged. They're present in the entire thickness of the endocervix up to the deep muscular layers, as evidenced by the large muscles, and occasional areas of very mildly pleomorphic nuclei that can well be an atypical reactive change with hyperchromasia and mild anisocytosis seen. I've got plenty of differential diagnosis over here. Mainly, some people have called it benign, but I have not come with a diagnosis. Many people have called it well-differentiated adenocarcinoma. So, let's get into the diagnosis. Gastric type adenocarcinoma, very good. It's a very well-differentiated adenocarcinoma cervix. Gastric type, also known as a minimal deviation adenocarcinoma. Why? Why should even those well-differentiated glands, why should they be surrounded by muscles? Why should they go so deep? There's no reason for the glands to go so deep. Okay? This diagnosis can be made just on H&E. But people, many times, and this is the most common mistake made in these cases, yes, should be differentiated from tunnel clusters, from lobular endocervical glandular hyperplasia, like microglandular hyperplasia. I missed out the N over here, sorry for that. But none of these extend deep into the muscular layer. Please realize, all these are more superficial. They look benign, they may show reactive change, especially microglandular hyperplasia may show reactive change, but they are more superficial. Why should so many glands go down deep into the muscle? That is the question you should ask. Actually, I have taken out more malignant aspects and given it to you for ease in diagnosis. In the slide, it was a more difficult diagnosis on the slide itself, but you should be thinking on this. It's the environment also which matters. You are seeing benign cells, benign glands surrounded by muscles. It can either be a hamartoma, okay, in which case you should be looking for the pleomorphic nuclei. You did find the pleomorphic nuclei, and hamartomas are well encapsulated. This is not. I'll just get into that, Mansi. And minimal deviation adenocarcinoma is HPV independent. How to differentiate it from tunnel clusters? Tunnel clusters don't go deep into the muscular layer. When it is superficial, not going into the muscular layer, it's very, very difficult to differentiate it from tunnel clusters. Very, very difficult to differentiate. I don't think, I wouldn't be able to differentiate. This I could differentiate because I could find no reason for a non-encapsulated mass with haphazard glands, seemingly benign, going deep into the muscle. In fact, if you see those thick walled blood vessels, they are near the outer surface of the cervix, going so much that it goes into the outer surface. Tunnel clusters or lobular endocervical glandular hyperplasia or microglandular hyperplasia, they do not have this. They do not have this feature. So deep, you may just find a hamartoma, but hamartomas are encapsulated. This is not. Over here, the glands are haphazardly arranged. So that's why this is actually only one differential. Over here, very well differentiated adenocarcinoma cervix, gastric tape. Okay, Mansi, does that answer your question? If it is superficial, you cannot really differentiate it from tunnel clusters. Its fact, its location, deep in the muscle, surrounded by muscles, going right to the outer layer of the cervix. That causes the diagnosis, along with the haphazardly arranged glands, focal pleomorphism. Okay, and I focused on that focal pleomorphism, which was very, very convenient, but that needed quite a bit of search from my junior residents. Okay, any other questions?
So currently there don't seem to be any questions. If we get questions in follow-up, I'll notify you, sir.
Okay. Thank you.
Yes.
As Dr. Vishal, the major factor in this was muscle invasion. Otherwise, with such a well-differentiated glands, it's very, very difficult to differentiate. What is the reason? Nothing. Okay. So, of course, for me, my session, these are the cases I had. Significance of stratification. My dear, any endocervical glands, stratification, as long as it's not pseudostratification, stratification is an abnormal feature. For adenocarcinoma in situ also, please realize stratification is a very, very important feature. Okay? And always, it was my juniors, Dr. Monica Singh, residents and technicians, we shout at them so much, but they have actually helped and they should be getting the credit over here. Thank you. I'll stop sharing.
So one question is there, if any IHC can help us differentiate this very well differentiated adenocarcinoma from any other type?
No, I don't know of any. Dr. Prashant, do you know of any IHC which can help?
No, sir. Even I don't think so. Again, this is the first case I have of adenoma malign, is so obvious. So even I can't recall any specific IHC from what I have read till now.
Okay. So I'll be taking your leave now.
Yes. Thank you, sir. Thank you so much.
Thank you.
Sir. And we are already getting demand for your next class, sir. So hope to see you soon. And I now hand over the screen to Dr. Prashant Joshi, sir, for continuation of the class. Thank you so much, sir, again.
You can, yeah. Are you?
So we can see the screen, but it's blank.
Let me just put this. I am share the keynote, WebEx and meeting window. Okay now? Or is it okay.
So can you unshare and share again?
So sharing anymore. I'm sharing now. Cannot. Yeah, now can you see it? Can you see the presentation?
No, sir. Yes, sir. Now
Oh.
I think there is a bit of delay. Now we can.
Okay, you can now, right? All right.
So it's not full screen, I guess.
Yeah, not yet. Now it is full screen. Yeah, you should be able to see now.
Yes, sir. Perfect.
Yeah, okay. So, all right. So far, that's what we saw the first 5 cases. So overall, I think 11 cases we had shared for the discussion of the exam cases. And overall, in general, these are the important points, I think, which just by practice and what generally the seniors hand down to the juniors. But since these are the cases we are discussing, mainly focusing from the exam point of view. So we are not discussing the entities so much in detail. But what would you write and what to do when you get these kinds of cases in exam? That is what at least I would focus more on the rest of the cases, right? In addition to the histological features and the descriptions, right? So in generally, histopath, whenever you get the cases, it's important for you to have a methodical approach for each and every case. Yes, so try to look at the slide without history first of all, right? So if you tend to look at the history and then look at the slide, some of the features you tend to miss because you get biased. You will get biased about the site, you will get biased about the tissue. Sometimes you might miss any unexpected findings, right? If you directly jump through the history. And generally slides will have many sections, right? It won't have just a single section. So look at all the sections, go methodically, examine the sections in a low power first and go to a higher power, right? And use specific descriptors, right? Which either are leading to a diagnosis or they are at least ruling out a diagnosis. So otherwise, generally it is not advisable to write 2 or 3 lines of very generic descriptions like the cells are medium to large size or medium to small size. They have a round to oval nucleus, scan to moderate cytoplasm, eosinophilic to pale, right? Most of the specific features don't come out when you're writing those things. And for most of our exams, you have 6 to 7 minutes per case. And if you spend at least 5 minutes looking at the findings and rest 2 minutes, it's better you put down specific features in points rather than trying to write paragraphs of non-specific findings, right? And we'll go through what I mean by classify as much as possible for you, given the case history and given the slide findings you are able to see, right? And when you're writing and summarizing, writing the impression for the each and every case, choose your words and phrases carefully, something which you can defend with whatever information was given to you, right? So even sir, in the previous 5 cases, he showed many cases where IHC was required for us to arrive at or narrow down a set of diagnoses, right? So in the absence of that, in exam, you have only one slide, right? You have one slide from a huge mass. So you have to give consideration to that as well when you are framing your differential diagnosis and your impression in the exam, right? Following that, you can advise for more sections, you can advise for IHC and take the discussion from there when you discuss the cases with the examiners, right? But your phrases in the impression which you write are important, right? That shows me how much you understand with what kind of a case you're dealing with, right? And advise further workup which is relevant to what observations you have made. Okay, so if you need a description, for example, you have described the entire lesion as a carcinoma only, right? And then in the IHC, if you start giving me markers like LCA, CD3, CD20, Desmin, then the description doesn't match with the way you're trying to work up the case, right? If you are advising LCA, CD320, I look for descriptions where you are having a doubt whether it's a carcinoma or a lymphoma to begin with, right? In the absence of that description, your further workup becomes kind of irrelevant, right? So avoid those kinds of mismatches within what you are interpreting and what you are advising further. Avoid writing generic descriptions and leading to a specific diagnosis. Generally, this is one of the worst things which can happen, right? So if your description is very poor, okay, and you have made a very specific diagnosis which cannot be made on a single slide without any IHC and without any special stains, it raises suspicion in the mind of an examiner whether you have asked the diagnosis to someone else who was part of the exam, right? And it doesn't matter if you don't get the answer right, the case diagnosis right, but if these kinds of incidents happen and if the examiner starts suspecting whether these findings are originally your own, the interpretation is whether originally your own or not, whether you have been helped by your senior resident who may be posted on duty for the exam or the another junior faculty, those kinds of incidents are best avoided in the exam setting, right? So best is not to ask for help. If you have attended your 3 years of course sincerely, you have seen your cases, you have observed faculty reporting these cases, trust me, if the case is difficult for you in the exam, it is difficult for everybody else, right? And on those cases, no one expects you to make the correct diagnosis. Okay. But if in those cases you don't describe well, you are unable to defend your diagnosis, yet you have written the correct diagnosis, that can land you in trouble, right? So with those basic points out of the way, we can go to the rest of the cases. Okay. So these cases are quite simple, and I'm not discussing too much on the special stains and the IHC, only the morphology and what kind of an interpretation you can make, spectrum you can have there. Right. So the first case here, there's a 74-year-old female who has had episodes of vomiting and loose stools. She's a known case of diabetes mellitus, and on endoscopy, they find a ulcerative lesion, the gastric pylorus. Okay. So upper GI endoscopic biopsy has been there in this case. So do we have anybody who can summarize the findings? Payal, Ayushi, Toyana? Anybody wants to do that here?
So here we can see gastric mucosa lined by pseudostratified columnar epithelium having goblet cells.
Okay, so we are saying gastric mucosa. Can you tell me what which part of the stomach is being represented here?
So body.
Okay, so stomach will have body, antral, and pylorus. Someone is saying antral. So how would you identify body and an antrum? Anyone in the chat can also type that. So someone's typed pale mucous cells in the antrum. All right. So did I tell you the site of the biopsy here? I have
Yes,
told
sir.
you the site as gastric pylorus, right? So you said, yeah, go on with the description.
So at foci there is loss of surface epithelium.
Okay.
The lamina propria shows irregular infiltrating angulated glands lined by neoplastic pseudostratified columnar epithelium.
Pseudostratified, do you mean these? Can you see my arrow?
Oh, sir.
Yes or no? Can you repeat that? Can you see the pointer I'm using or no?
No, sir.
No. All right. Okay. So okay, so you are seeing some cells which are okay. Okay, somebody is typing foveal hyperplasia there. Okay, now can you see the arrow?
Yes, sir.
Yeah. So you mean these cells where you are saying there is a pseudostratified and epithelial cells which you call neoplastic?
So in glands I saw pseudostratification.
All right. So in this you are can you repeat where did you place this mucosal fragment? Did you place it in the body or did you place it in the entopyloric area?
So antropyloric area.
You place it in the entopyloric area. Fine. I agree with that because there are no synthetic cells here. These are all just the foveolae. And underneath that, you can see all the different types of cells, which we are to see there. Okay. This is just a higher power of the same. Okay. And what fragment is this? Payal, you are answering, right? Okay. Kritarthi answers that's a polyp. And there is foveolar hyperplasia. Rachita, why are you saying there's a foveolar hyperplasia? So we can see some of them, they are torches here, right? They seem to be elongated. And this here, what fragment do you think is this one? 1? 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1 1
Lamina propria only.
Okay, so lamina propria. Okay. And what kinds of glands are there in the center here? So here we are able to see the pyloric type glands, right? Underneath the foveolar mucosa. So we are at what the biopsy site they had told us. We are seeing the representative tissue, right? The gastric mucosa belonging to the antopyloric area. And I agree that the foveolar epithelial cells, they are elongated. The foveolar lining is elongated. It's tortuous, right? And what do you feel in this focus? Do you feel these glands are atypical enough to consider a carcinoma? Do you feel these glands are showing reactive ATPR? Do you feel these glands are dysplastic? Somebody has said cryptabscesses. I agree there are neutrophils in the lining of the crypts here. But what do you feel about the nuclear changes here?
Atypical reactive changes.
Reactive.
Okay, so I'm getting a few dysplastic answers. I'm getting two of you said reactive. So how do you decide? What is the guide which we can use to decide whether a gastric epithelial or a gastric gland is dysplastic or not?
Nuclear irregularity.
Okay, what do you mean by that? Do you look at the membrane? Do you look at the location? What do you look what do you see for when you say nuclear irregularity? You look at polarity. Okay, by polarity we mean whether the nucleus is located basally or they are located in several layers. They are whether they are going to the membrane or not, right? We can look at the differential status of the cell itself, whether it is retaining that Lesion cap or not. Okay, and anyway, whenever you are trying to see whether there is any reactive atypia or dysplasia, look at the attendant pulmonary activity. Yeah, surface maturation is very important. Again, in this case, we can say that the neutrophils are clearly infiltrating into the glands here, right? And the nuclei, it's a single layer, is located basally, okay? They're only mildly enlarged. The nucleus is conspicuous in many of them, okay? But still, I would not call these glands as dysplastic, all right? Now, here, what do you see?
Neoplastic cells.
You are able to see?
Yes, sir.
Tumor cells.
You're able to see tumor cells. Okay. So anything else other than that tumor cell? Is everything in this field looking like a tumor to you?
Inflammatory infiltrate.
Yeah, there is an inflammatory infiltrate. Somebody has said mitosis. Okay.
Desmoplasia.
Desmoplasia. Okay. Not really. I don't think there is any desmoplasia here. There is a little bit of smooth muscle on the, yeah, blood vessels, right? Can't you see a lot of blood vessels in this field?
Yes.
Yes, most of the structures here are blood vessels, right? Okay, and what do you think of the cell in the center? There is a blood vessel there, right? And there's a large cell in the center. Can you see that? Now it's in the center of the field. What do you think of this cell? Do you think this is a tumor cell or can it be something else? Okay, someone said herpes simplex virus. Someone said macrophage. Okay, anything else? So remember this cell and try to identify this. Okay, you want markers. That's what. If I have to use a marker, I have to get out of this full screen. So is this view okay or not? Because I can use the marker here. These are the cells I'm talking about, right? Yeah, is this view better? Shall I continue with this? So someone said signating morphology. I agree. This cell has a signet kind of a morphology. Nucleus is pushed towards the periphery. There is cytoplasm, which is pushing it outside. Can you identify the same cell here? And where do you think that cell is located? Right? Aren't these blood vessels? Right? These are blood vessels, and within the blood vessels, we are seeing some of these large cells, right? And we can see that same cells in and around several of these blood vessels. That's another large cell. Again, it's single. It's not forming any cohesive structures. Yeah, it's not forming glands, not forming sheets. It's there only in this fragment of granulation tissue in and around the blood vessels, right? That's one. That's another one. That's another one. Here again, right? This is another one. They are singly lying. Yes, they are singly lying cells. So okay. What do you think of this? This is another similar singly lying cell with enlarged nucleus, right? The chromatin pattern is very different compared to the rest of the cells. The cell is larger compared to other cells, right? The chromatin is becoming smudgy. So at the end of this, what do you think? So summary of findings, we are seeing this, right? There is pyloric gland, there is representative mucosal fragments. That is what we are seeing. Okay. And we are seeing reactive changes in the epithelium. We are seeing enlarged cells, which are most likely endothelial cells, right? Because they are along the endothelial capillaries, the way the capillaries they are flowing. Few of them we could clearly see they are located within the endothelial channels, right? And there is altered chromatin. They could be viral inclusions. Yeah. So some of the answers I'm getting, Rachita says they could be CMV, SK says cytomegalic cells. And within the blood vessels, Preeti agrees. I also agree they are all mostly within the blood vessels. Cytoplasmic vacuolations are there, right? And there is no metaplasia, right? Gastric enteral with inflammation, we generally look for intestinal metaplasia and we look for dysplasia, right? So these are the summary of the findings. So with that, what would you write as the impression or diagnosis for this case? So if this case comes as an exam case for you, how would you go about this? A, B, C, D, or E?
D.
Yeah, Royan, I'll go back to the endothelial cells. Yeah, I'll just spend some time here. Okay, so I've got some B's, one B, B of reactive ATP. Okay. I've got one more B. Two of you think it's reactive atypia, advise follow-up and repeat biopsy. So why would you want a follow-up and a repeat biopsy in this case if you think it's a reactive atypia? Can you justify that? Amrita and Khushbu. Right, herpes simplex virus, we didn't see. So what are the features of herpes simplex virus? What are the cytopathological changes which we see in that? We see multinucleation, we see molding, we see margination. Yeah, that's the one. So we didn't really see any of those changes here. Yeah, margination, multinucleation, and molding. Okay, so here I'm happy that none of you said a very vague diagnosis of acute or chronic gastritis. That is one. None of you said it's suspicious for malignancy. Okay, that's enough. Initially, we were thinking of this hyperplasia and a polypoidal structure going on, but once we've seen enough inflammatory activity, we saw the granulation tissue, we saw the endothelial cells with those changes. I'm happy that none of you went with the other options, right? So the discussion here would revolve around that. Were you able to identify, first of all, were you able to pick up those cells, right? Because in the exam, if you have 6 or 7 minutes, in this focus, try to identify, because granulation tissue, very rarely any of us will try to focus and see what's happening in the endothelium there, right? So you should be alert enough to identify any abnormal cells which are there in this foci also, right? And in this case, at least there are few of them. But even if you miss this, you should not go in another direction and misinterpret these as atypical glands and give a possibility of adenocarcinoma or a high-grade dysplasia, right? So that as an examiner, I would take it as an overinterpretation, right? Especially when there is a lot of granulation tissue, when there is a lot of acute inflammatory activity occurring, right? The bar to diagnose a dysplasia itself becomes higher. And in this slide, in the images I've given you, there is nothing which is convincingly dysplastic anyway. Okay. I'd be happy during the exam if any of the students focuses on these cells, right? Recognizes that there are some large cells in the granulation tissue fragment, right? Very happy if they recognize that they are associated with the endothelial cells, right? Here we can see this is the capillary outline, okay? And we can see that cell is bang in the center of that, right? So endothelial. So once you add these two together, that there is endothelial cells and within the endothelium there are large cells, it directly leads us to viral inclusions, right? So, okay. So in this case, B is fine, D is fine. B, you would have to justify why you're asking for a repeat biopsy and why you're advising a follow, right? Unless you are wanting any specific information. Otherwise, the description would be important. I would specifically look whether you have bothered to comment on whether the gastric biopsy belongs to the antrum or the body or not, right? Because we need to first decide whether the tissue we are examining on the slide, whether it is appropriate for the clinical setting or not, and the nature of the biopsy which is claimed to have been submitted, right? Otherwise, you will miss a lot of the mismatches, and some examiners do bring cases, right, where there is a mismatch between the history and the type of the slide being given. Okay, sometimes it could be a mismatch in the number. The history will say that the grossing found 4 or 3 gastric biopsies, right? Whereas in the slide you would be seeing multiple 5 or 6. So in that case, you should be able to recognize that. And sometimes you should be alert enough to pick a floater, for example, right? So if the slide is showing a malignant lesion and clinically there is nothing described, say for example, in the upper GI endoscopy, I say there is no ulcer or proliferative lesion, just some whitish lesion, and they're suspecting lymphangiectasia or some other benign lesion, right? So that should alert you to the possibility that this case, there could be a mix-up, there could be a floater. So then the discussion goes along that line, right? So if you're not alert enough to recognize that, then the case discussion, basically you won't hit the target there, right? Even though your histological findings were correct. So first make sure that that condition is satisfied, that you're interpreting the appropriate tissue for the clinical setting which is being given to you, right? Then you have to decide whether it's normal and whether it's not normal. Within not normal, whether the lesion is inflammatory or neoplastic, right? So here clearly the lesion was inflammatory. Whether it was infective, non-infective, many features pointed to the CMV viral inclusions there, right? But here again, the classical ovoid inclusions, which we see with the bright, large eosinophilic center in the nucleus, that was not very apparent. Okay, so here the features were just suspicious for CMV. I would not be definitively CMV on this. I would like to correlate either with the CMV immunoglobulin in the serum or do a CMV IHC. I would raise a suspicion though, definitely, right? And there's no need to raise a concern of malignancy in this case or dysplasia also, right? So any questions in this? Do you agree with what we would want to do in this case? Or do you have any other options which you would have given if you saw this case?
Box.
Atypical reactive changes, considered borderline lesions. Okay. Atypical reactive in the sense, are you talking about the foveolar epithelial changes there? Okay, but I don't think the epithelial changes are to that level where it raises a suspicion for dysplasia. Right? Look at all these cells, right? These are the cells which are looking most abnormal, right? These are clearly benign. We are seeing those 4 lines. Okay, so there's a basement membrane, the nuclei are all located towards the base, then there's a mucin cap, and then there is that glycocalyx, right? So once the gastric epithelium and the foveolar mucosa is showing those 4 lines, it means its polarity is maintained and it is essentially retaining its functionality and the benign nature. Here, all that is happening more is that it is more eosinophilic, right? These are all pyloric type glands which are showing this neutrophilic infiltration in the border, right? And we are seeing a range of the nuclear sizes. Some of the nuclei are small, right? They are merging into some larger nuclei. With nuclei also, some they are conspicuous, some of them they are prominent, and some of them they are not there at all. So dysplasia would not have that. Dysplasia would have clearly one type of cells which are very different from the rest of them. right? So once you see this spectrum of changes in the cells, it favors reactive lesion more. Okay. Again, here it's a matter of opinion. Sometimes, like this, most of the people I know would favor this as reactive, right? But if you are wanting to discuss that, I am not able to rule out a dysplasia, but I would want to then test you on what are the features you are looking for to differentiate a reactive gland versus a dysplastic gland, right? And if those features, like what we discussed just now, if you answer those, I'm happy, right? I don't need you to make the diagnosis which I have made. I want to test whether you have a methodical way of approaching that question whenever you arrive at that. Whether when you're trying to decide whether a gastric gland is reactive or a low-grade dysplastic, how are you going about doing it? That is all I want to test here. All right. So it is fine if you want to go reactive and say, I want to follow up and see whether after the inflammation reduces, whether the same lesions are persisting or not. That's also acceptable. All right. So we'll go to the next case one. Okay. So case 7, this one is a 50-year-old male on HART therapy presenting with dyspnea, and we have a transbronchial lung biopsy now. Okay. And Payal did the last one, right? Ayushi or Royana, would you want to describe this one? Ayushi or Royana, are you there? Are you able to speak?
Yes, sir.
Yeah, please go on. So what do you think is this tissue? Okay, second case, you want to see the history. History is a 50-year-old male. Patient is on HART therapy, that is highly active antiretroviral therapy, right? Presenting with dyspnea, and the patient underwent a bronchoscopy followed by a transbronchial lung biopsy, right? So we are seeing lung biopsy tissue basically. Right, so clearly we can see alveolar spaces, and Kritarthi is saying hyaline material can be seen. I'm not so sure. So are you saying this is all the hyaline material? Okay, so see, this all looks like procedural hemorrhage to me. Yeah, so this is all procedural hemorrhage. Hyaline material should be lining the alveolar spaces, right? So here what we can see is this one is the entire chunk of the pulmonary alveolar tissue, right? And here there are some alveolar spaces, but most of it outside, this is all RBCs which are procedural. Here there is another pulmonary tissue, right? Here there is some fibrin. So not, and I think none of this is lining the alveolar lining here, right? So okay, so mostly they are alveolar spaces, and wherever we can see the alveolar outline clearly, I don't see any bright pink fibrinous material lining the surface, right? So low power, not a major finding, okay, of hyaline space. Anything else you can observe in the low power? Edema at the corner.
Exudate.
Sorry?
Sir, exudates, intraalveolar exudates.
Interalveolar exudates. Okay, so this is what you're saying, right? So there are some collections within the alveolar spaces we can see. That's an important finding here. All right. What do you think of the interstitium?
So thickened.
Thickened. So
Alveolar
at places, yeah, in many places it is thin, and some places it is thickened. Eosinophilic globules, this is just artifact if this is what you're referring to. All right. Let's go to the next one. Okay. So this is a closer view of that area where we thought there were intraalveolar collections, right? So what do you think this collection is made up of at this? Yeah, there is eosinophilia material. Okay, this material inside the alveolus, yes, it is there. Here, there are some alveolar septal thickening. Then what do you think this alveolar, interalveolar collections are made up of? Right, this is a higher power of that collection. Can you describe that a little better? So at a low power, we thought they were exudates. What do you think they are now?
Sir, foamy histiocytes.
Foamy, yes. Histiocytes, think again. Are you histiocytes? You should be able to see a cytoplasmic border. You should be able to see a proper nucleus, right? Here, for example, I can see a few nuclei, right? What about this? Are you able to see so many nuclei here corresponding to so much of the eosinophilic material?
No, sir.
No, right? So it's not entirely cells. Mucin should be bluish in color, not so much of a blue tinge also. Proteinaceous material, okay. But she also said foamy. I agreed with foamy. Proteinaceous material, if it is fluid, it will be like this, right? Can you see those rounded things here? Okay. Parasite, you're saying for this? Intraalveolar? What structure is making you think of a parasite here? Parasites, generally we'll see a thick wall, we'll see some internal structures. At the same thing, here we are able to see a few more cells, but again that foaminess is there, the eosinophilic debris is there. Lipomatous material, okay, it is whitish, but not big enough to be called fatty material. Okay, and why would you get fatty material inside the alveolus? What conditions do you expect to get that?
Embolus.
Yeah, embolus, but where is the embolus going? Is it going and will it form an aggregate inside the alveolus, or where are you going to find the fatty embolus which can come from a fracture? You're going to find it inside a vessel. Yes?
Yes, sir.
So somebody's used the word frothy here, and query pneumocystis has come into the picture now, right? Priya also thinks it could be pneumocystis. Vasudha thinks it is pneumocystis. Ayushi thinks it's fibrous material. Fibrous material inside the alveolus is unlikely because the alveolar outline is retained, right? If there is fibrosis which is occurring in the alveolus, it would distort the alveolar space. Okay. Cells with vacuolated cytoplasm, yes, but everywhere there is no corresponding nucleus to go along with it, right? The vacuolated material is sitting separately, right? Devoid of nucleus here. So there is some foamy material with eosinophilic granular debris, right? That we can deposit. Fibrin would be very bright, okay? And fibrin won't form this kind of rounded spaces in such a regular repetitive fashion, right? Fibrin would be a random meshwork of filaments, right? And if there's a lot of fibrin, it generally gets accompanied by hemorrhage, congested vessels. And if the fibrin is there, it will end up lining the alveolar spaces. Okay, so some unlikely to be fibrin again. This is the highest power I can show you, right? So there are some of these alveolar histocytes are there, and then we are seeing this foaminess, some of which are appearing bluish. Okay, this is the one where there are barely any nuclei. Everything is this granular debris material within which we can see these rounded structures. Okay, can you see those? All right. So with that in mind, this here is, what do you think this one is? Can I have some answers for this? Do you think this is similar to what we have seen so far, or is it looking different? So we have seen some frothy material with those rounded structures, some granular debris and macrophages earlier. Yeah, soap bubble appearance, I agree. For what we have seen so far, I agree with soap bubble. Here, mucin, okay, it is bluish material. But what are these spindle cells doing floating around in mucin? Right, these are all spindle cells, these are fibroblasts, right? So in lung, acute lung injury, this is one of the way the interstitium responds, right? So these are fibroblastic cells which are trying to repair, and this is how fibrin will appear, this much dense and bright pink thick deposition. Okay, so with those features, and this is the lower power of that fibroblastic focus with this myxoid material, right? Trying to plug and repair something there. And this is a pass stain, right? These rounded spaces are getting highlighted. They are standing out better compared to the background. Okay. Same thing is there here. So with this, what do you think now? Summary of findings: we are seeing pulmonary alveolar tissue, right? So it is they have said they have done a transbronchial lung biopsy, and we are seeing transbronchial pulmonary tissue, right? So alveolar tissue we are seeing. We are seeing focal interstitial widening. There is inflammation. Focally, there is a fibroblastic plug. Then we are seeing intraalveolar pink, foamy, frothy, right? Amorphous material with cell debris, right? So many answers. Many of you are saying PCP, PCJ, and so we'll look at what would you write as the impression now, right? Given, I agree it is looking like pneumocystis, but there is many ways through which we can convey that information, right? Given what you have seen so far, I've told you it's a 50-year-old male. I've told you the person is on highly active antiretroviral therapy. I have not shown you GMS, okay? With that information, which one of these do you think is the most appropriate bottom line to put? Okay, suspicious, possibility cannot be ruled out. Suspicious, possibility cannot be ruled out, possibility cannot be ruled out. Okay, so among C and F, which one do you feel indicates a higher degree of certainty that it is a pneumocystis pneumonia? Does F indicate a higher certainty or C indicate a higher certainty? Yeah, I agree with C. C indicates a higher degree of certainty. Suspicious for pneumocystis pneumonia. So how would you confirm in this case? We would do a GMS, right? C, even I agree with that. Okay. And different ways, basically, you can use different descriptors when you want to indicate different degrees of certainty, right? So you need to have some idea of what different descriptors mean, right? And you have to do it consistently, at least internally, because ultimately report is a form of a communication, right? And when you have seen the slide and with a one-line history and a single slide, in every case you will not be able to make a certain diagnosis, right? So in this case, at least we have seen enough to be suspicious of a PCP, right? Isn't E the sure way? Sure, E is the definitive one, right? So if in this case, for example, if I do the GMS and I see the dot in the organism, and if I'm able to rule out other artifacts, okay, rule out mucin, rule out cell debris, right? Then I would call it just as pneumocystis pneumonia. I would not use any other descriptor there, because now I am sure I have confirmed, I have ruled out histoplasma, I have ruled out other fungal organisms. I can say it is definitely pneumocystis pneumonia, definitely. But in exam, this is what happens, right? Exam, we don't give you the entire set of slides for you to make up your mind definitively, right? So try not to be definitive where it is not called for, okay? But if you're definitive, then you should be able to defend it, right? If you give a single line diagnosis, that is what even Nilotpal sir was saying. Don't take differential diagnosis as a sign of weakness. Don't think that I am unable to make a single diagnosis and therefore I have not done a good enough job, right? In exams with one slide, one line diagnosis, no radiology, no clinical correlation, right? No special stains, no IHC. Seldom you will be able to make a single line specific diagnosis, right? So, and differential diagnosis and the way you approach, what you advise further, in fact, shows your maturity, right? I'll be very happy if someone works up and presents the case that way, rather than giving me a single word diagnosis at the end of a vague description, right? Even though it is correct. Okay, so cannot be ruled out goes towards the lowest end of the certainty spectrum, right? There is no positive histological evidence and it's the weakest statement. Suggestive, there are some supportive features which we can see, but it is insufficient for the diagnosis alone. Compatible we'll use when it requires clinical and radiological correlation, right? Morphology generally fits well with that entity, but it can happen in other entities also, right? So we'll say, and compatible with generally we'll use exceedingly often in derm path, right? Because same set of histological findings can be seen in different diseases, right? Suspicious raises a strong concern, right? Histology itself is raising a concern for a specific diagnosis. And of course, diagnostic of is the highest confidence, right? There we don't have to use any adjectives or any descriptors. We can directly say impression, pneumocystis pneumonia, or impression, squamous cell carcinoma, impression, adenocarcinoma. We don't have to raise any uncertainty. So therefore, at least in the routine reporting, we need to avoid these kind of descriptors as far as possible. We try to be as specific as possible. If we have to use these descriptors, we should use it internally consistently such that our clinicians understand what we are trying to say. And if you use it, you yourself should be able to explain why you have used those words. Okay. So that case was meant for this discussion. And any questions in this? Then we can move on to the next one. Okay, we'll go to the next one then. So this one is a spotter straightforward case. So here, no history. You won't need any history there, right? I'll spend a few moments. All of you can look at the slide, and then I expect quick answers. Higher power of the same. Primary tissue is not a problem. Let me know if you want to go back to the images. I'll go back and wait. All right. Okay. Hydrated cyst. Why do you think a hydrated cyst? Because of this. Okay. We'll come back to that. Okay. Somebody says gout. Some Mansi says fungal infection. Okay. Actinomycetes, definitely. Okay. Metastasis. All right. Got fungal. I'll run through the images again, right? This is the low power image. This and this, right? Higher power of the same thing. Different area on the slide, right? This is what I want you to look at. And this is a higher power of that same area. What do you think now? Cotton wool is there, I agree. Actinomycosis is there, I agree. What about this? People who have said fungal have ignored the actinomycosis. People who have said actinomycosis have ignored this. What are these? Yeah, they are aseptate thick hyphae. Yes? Right. So it is basically, yeah. So I think hydrated cyst, who said Maithili, maybe you looked at this, you looked at these parallel lines and thought of the wall of the hydrated, possibly. But this is clearly bone, right? These are all trabeculae of the bone. We can see these empty lacunae. What do these empty lacunae signify? These empty lacunae signify that this is a necrosis. Very good. That this is a dead bone. It also signifies it's a lamellae signifies it's a lamellar mature bone, right? Not the woven and the immature bone. Empty lacunae signify that all the osteocytes which were there inside, they are now dead, right? Same thing can be shown by this basophilic outline, okay, the fragmented outline of the bone. So this is dead bony tissue, right? And all this cotton wool like appearance or the sunray appearance, all these filamentous bacterial colonies are growing on top of this dead bone, all right? But the findings don't stop there, right? In one of these spaces, you're also seeing the aseptate fungal hyphae. So essentially, this is a kind of an exam case where you have two findings, not just one. So many of us, what we would do, we will look at actinomycosis, which is the most predominant finding here, and call it as actinomycosis bone and end up describing it and ignoring this kind of a minor finding here, right? So it always pays to examine all the sections on the slide. Even if you get a single finding within the first 30 seconds of the slide, right? Take the effort to look at all the sections and look at all the areas. Make sure to not miss anything else, right? Because this is again, these kinds of slides we end up often seeing in a report, right? And even this one, because we realized that this had mucor because it was written on the form that the KOH mount, and this was from the oral cavity, right? So mandible, there was an ulcer and it wasn't healing for a long time. So they had done a KOH mount, and KOH mount had found the mucor as well, right? So the form had the mucor, therefore we searched for it, and look at this. These are 3 different sections on the same slide. Okay. In one of these, we barely see any mucor. Right. If you look at the other sections, you'll end up finding these filaments. Right. So some of the double mixed infections can be very subtle. So in the first 30 seconds, if you're able to make a diagnosis, right, take the effort and see all the sections and make sure you're not missing anything else, especially if you get a history like a patient is on antiretroviral therapy, right? That again is a scenario where you can get mixed infections very commonly. Even in the lung, even the textbooks tell you, like if you're able to identify a pneumocystis infection in the lung, take the effort and rule out other coexistent infections and well. Look for CM inclusions, look for viral inclusions, right? So this kind of case, make sure you do that. Pap smears, very often people get cases where there are double findings. There might be a squamous intraepithelial lesion along with either candida, right, or any other feature. There can be a agus going along with site. Okay, so always remember there can be 2 diagnostic features on the same slide. Right, so this case was meant for that. And these sections, don't just examine one section in detail and completely ignore the rest of them. Okay, those are important for exam. Okay, so that was a spotter. Going for the next case, this is case 8. Again, this is relatively straightforward, so we can finish this quickly, right? So here we have 2 tissues, again a core biopsy. We don't see any normal terminal ductlobular units here. We are seeing fat and we are seeing a lot of activity here, right? Some places it is concentrated. We can see this is infiltrating the fat here. Okay, and here we are able to see these are thick, broad trabeculae of these cohesive cells. Okay, and in between there is some stroma. There are a lot of these smaller cells, likely inflammatory cells, which are there. This is a little higher power. Again, we can see that there are no duct formation. There is no lumen formation here. There are no papillae, right? Then it's all just sheets of cells, intervening stroma and inflammatory cells. Okay, here again, okay, I'm getting answers of lobular carcinoma. Any other possibilities? Give me the possibilities here. What do you think here? Okay, Ayushi thinks of, is it an invasive carcinoma or is it a lymphoma? Very well, that is what medullary carcinoma of the breast is also a possibility, right? Solid and pleomorphic with lymphocytic infiltrate. Medullary pattern is there. Medullary pattern is there. Yeah, but in an exam case, all you are seeing is a core biopsy, right? So with these findings, what do you think your bottom line should be? Right? Again, these are all the features. Okay. So what would you write the impression here? You would say invasive breast carcinoma NST grade 3. Fair enough. You would say non-Hodgkin's lymphoma as the only diagnosis. Ayushi? IBC NST is fine, acceptable. But again, like for people, those among you who are giving a single diagnosis of invasive breast carcinoma, I would look for the appropriate descriptors in your description, right? I would confirm whether you have described enough to bring out the epithelial nature of the proliferation in that, right? That is what I will look for in your description. I will see whether you have used the words cohesive, right? Whether you have used the word sheets, okay? Whether you have looked for those tubules and ducts, or else you should yourself be able to convince why you thought of only epithelial differentiation there and why you could rule out the other, like some of them here thought of non-Hodgkin's lymphoma as well, right? So Ayushi, why would you think of only a non-Hodgkin's lymphoma here? Right? So there are some features which are indicating a cohesive proliferation here, right? Non-Hodgkin's lymphoma would not form a very well-defined structure like this. Yeah, but if in the absence of this, like in areas like this, it's really difficult to make it out, right? We are unable to see the cohesion between the cells. Yeah, so NHL is still a fair differential diagnosis, I would say, but not appropriate single diagnosis. Some of you are saying C, yeah. So at least from my, this is for my reporting cases, this is what I did. I gave a differential diagnosis of IDC versus non-Hodgkin's lymphoma, right? So CK, LCA, those are the two markers those were enough to sort it out, right? The tumor cells came positive for pancytokeratin. These all were highlighted on cytokeratin, and all these inflammatory cells, which are lymphocytes in between, were getting highlighted with LCA, right? So I could prove the epithelial differentiation, right? I could suspect epithelial differentiation on morphology. I could prove it on IHC, and therefore, after the IHC, I could give it as a single diagnosis of an invasive breast carcinoma, NST grade 3. Right? There is a medullary pattern, but again, medullary carcinoma, we can only diagnose after resection. We have to rule out any other component, whether the IDC component is there or not, whether it is purely medullary pattern or not. So for the for the biopsy on a single slide on an exam setting, C or D are acceptable for me, right? E, I would really ask you why you thought of only a non-Hodgkin's lymphoma, and how were you able to rule out possibility of a breast carcinoma, right? That is where the discussion would go. Why not lobular? Lobular, one, the cells are too pleomorphic, the cells are too large, they are forming these cohesive sheets, right? Lobular, the characteristics is mainly they are small cells, bland cells, discohesive Indian file pattern, right? So not many, in fact, not much features in favor of lobular, right? The nuclear are also quite prominent. So here we would be thinking of high-grade invasive carcinoma versus non-Hodgkin's lymphoma, the large cell type, right? These are the images which you are seeing, right? So in this morphology, the lobular is not really entering my differential. Any other questions with this case?
Not currently.
Okay, so we'll go to the next one.
Yes, sir.
So case 9, this is a pleural biopsy. Again, a classic exam scenario and a very common chapter topic also, right? Theory answer as well. So pleural biopsy, here we are seeing a lot of this pleural tissue, right? On top of it is a lot of proliferation. Yes. Higher power of the proliferation. Okay, composed of pleomorphic cells, some smaller cells, some larger cells. This is the higher power of the surface, right? The cells have abundant cytoplasm. Some of them are smaller in size. Prominent nucleolus can be seen. Case history, all right. So case history is a 58-year-old male with a pleural biopsy. So a lot of things have not been told here, right? So it's important to keep that also in mind. Okay, so that should directly affect what we are willing to write as the bottom line in our case, right? So it's only a pleural biopsy. We don't know whether there is a mass. We don't know whether there is a thickening. We don't know whether the mass is circumferentially encasing something, right? We don't know whether the lung pulmonary parenchyma itself has any nodule or not, right? So a lot of the things are left unsaid here. That should directly have a bearing on what kind of bottom line we are writing, right? So go ahead with this, right? The pleural biopsy. So in this setting, what you are willing to write, right? That is what I want to discuss here. Okay. So there is some amount of surface proliferation, right? This is the pleural stroma, and we can see a lot of proliferation is occurring on the surface of the pleura. That is what we can see in this, right? Okay. So Avita is thinking of mesothelioma. Somebody says malignant mesothelioma, large cell carcinoma. Okay. But so far you have not seen enough to decide, I would say. Okay. All we are seeing so far is surface level proliferation, right? Preeti is thought of meta as well. Okay. Here again, there is a sheet-like proliferation. What do you think these cells are differentiating along? Are they differentiating along mesothelial lineage? Are they differentiating along epithelial? How do you make it out? How are you able to decide so quickly that this is mesothelial? Okay, here we are now beginning to see that these cells are not just limiting their proliferation to the surface, but they are going inside as well, right? And they are going inside in the form of very small clusters. Some places in the form of single cells also, right? They are going along this, okay? Right, here again we can see desmoplacia, right? More of desmoplacia and randomly infiltrating cells within the pleural stroma, which is very thickened and which is very fibrotic, right? So this entire thing is showing us very haphazard proliferation of these similar epithelial cells, okay? So what do you say when you mean by METs? Is it coming from outside the thoracic cavity? What do you want to indicate when you are thinking of metastasis? Or are you trying to say it could be a direct spread from the lung tumor? And here we are seeing mitotic activity as well, right? Even within the cells which are there in the pleura, right? We are seeing some atypical mitosis, pleomorphism is there, or mitotic activity is there. Again, so somebody has brought in squamous cell carcinoma now, correct mets, direct spread from lung tumor. So everything is possible basically in this, right? So here again, the tissue seems appropriate from the clinical setting. They have said they have sent a pleural biopsy. It does look like a pleural biopsy, right? And definitely not normal tissue, right? Is it inflammatory? Is it neoplastic, right? Many features are there which indicate that it is neoplastic, right? So in your description, I would be looking for those set of features, right? I'd expect you to write that there is haphazard infiltration, there is some desmoplacia, right? There is fibroblastic proliferation, right? Things which could basically rule out an inflammatory entity, right? Because in mesothelial proliferation, many of the inflammatory mesothelial proliferations can be quite striking, right? But there again, some level of organization gets maintained. So this would be important. Like if the discussion hinges around this, whether you want to differentiate it from reactive versus neoplastic, I would ask you what special stains you can use to differentiate a reactive mesothelial proliferation versus a malignant process which is occurring there, right? I would ask you what is a sure short sign which on a biopsy you can see which indicates that this is definitely a malignancy, right? So one of the important features, especially in these pleural type biopsies, we look for is there any fat which is surrounding the parietal pleura, right? So if these lesional cells are infiltrating into the fat, that is a sure short sign of a malignancy, right? But otherwise, because sometimes even these reactive mesothelial proliferations can also induce fibrotic thickening of the pleura, and they can be quite haphazard. Reticulin stain is one of the things which helps you there, right? To see whether the reticulin pattern of the pleura is preserved or not. That can help you. Atypical mitosis can help you, definitely. Yeah, calretinine won't help you in differentiating inflammatory versus neoplastic. Yeah, it can tell you whether it's a mesothelial as a part of a broader panel. It can help you in differentiating whether it's mesothelial or epithelial, right? So first, we decide whether it's inflammatory or neoplastic, right? Make sure you write down the findings whichever way your mind is taking you, right? So if you are able to identify more features which take you towards inflammatory, write them down. If you are identifying more features which take you towards neoplastic, write them down. With the neoplastic, again, decide whether it is benign or malignant, right? Definitely these here there are enough ATP and enough mitotic activity to rule out a benign process here, right? Then we come to lineage. Is this haphazard proliferation which is looking neoplastic of epithelial origin, or is it of mesothelial origin? Again, here some morphological features can help us. So make sure in your description you show that you have looked for those features, right? You write that there are no glands I could see. You write that I couldn't see any keratinization, right? I could see some glassy, abundant eosinophilic cytoplasm, which is raising a suspicion of squamous differentiation in some of you, at least I could see, right? But doesn't mean it's definitive keratin and definitive squamous differentiation. So all you can indicate here is give those findings that I could see those more cytoplasm. I couldn't see any glands. I couldn't see any papillae, right? I couldn't see any intercytoplasmic mucin, right? That tells me that you have specifically looked for that to try to identify which line the differentiation is going along, right? Is it epithelial? It is mesothelial. And of course, primary versus secondary is always there whenever we talk of lung. So once all that descriptive points are there, then we can talk of what kind of impression or diagnosis you would like to give here. You think is appropriate, given whatever we have discussed so far. right? So exam, all you have got is 50-year-old man, there's a pleural lesion, and these are the findings you are seeing, right? Okay, PDMT. Sachita says it could be a poorly differentiated malignant lesion. Okay. F is for NSCLC, favors squamous cell carcinoma. All right. D is mesothelioma. F is favor squamous. F is famous squamous. So tell me, in what kind of a context do you use NSCLC favor squamous cell carcinoma as a line diagnosis? Anybody who has their audio on can answer this, because this recommendation is very clear, right? The favor squamous cell carcinoma, when do we use that phrase? Okay, keratin pulse, B and C, poorly differentiated, differential diagnosis. Okay. Again, a poorly differentiated malignant lesion, some people like to use this word. Again, this is generally a terminology which is used in cyto, right? Where we know that it's malignant, but we are unable to point towards its lineage, right? We are unable to give specific diagnosis, or they are very broad enough. It could be melanoma, it could be lymphoma, it could be carcinoma, it could be germ cell tumor. Even in those cases, I feel using the word poorly differentiated just based on morphology without doing any IHC or further workup doesn't make sense to me, right? Because once we do IHC, we know that it's a differentiated carcinoma, or it could be a differentiated melanoma or a differentiated germ cell tumor. So generally, if you want to give differentials, directly choose the C option, right? If you have a set of DDs, like for example, here we are thinking of non-small cell carcinoma, here we're thinking of mesothelioma, right? Directly say the differential diagnosis considered are 1 and 2 in your order of preference, whatever it is. E and F are definitely wrong, right? If you are thinking, if you are able to favor non-small cell carcinoma over mesothelioma due to X and Y reasons, right? Go with G. So why are E and F wrong? Because as per the WHO recommendations, right, on a biopsy, when do we say favor adenocarcinoma and when do we say favor squamous cell carcinoma? We say it only after IHC, right? We don't use this description on morphology alone. In a lung tumor, if the morphology is clearly adeno, we say it is a adenocarcinoma. If it is clearly squamous, we are able to see intracellular bridges, we are able to see keratin pulse, we directly call it as squamous cell carcinoma, right? Yes, that's the answer. Like Mansi is saying that IHC. Use the words favor adeno and favor squamous only after IHC. So in a non-small cell carcinoma context of morphology, once we do your P40 and TTF or P63 and TTF with or without napsin, if the TTF1 comes positive, we favor adenocarcinoma. If P63 or P40 comes positive, we favor squamous. So just based on morphology, using this terminology would be wrong, right? That indicates that you specifically are have not paid attention to when this terminology is to be used, right? As recommended by WHO. WHO doesn't recommend this kind of terminology for every scenario, right? In lung, it has. So, and lung biopsies are very common and even routinely biopsied nowadays, right? So most of us would have seen lung biopsied being worked up for carcinoma. So this I would expect most of the exam going PGs to know when to use a favor adenocarcinoma, when to use a favor squamous, when to use just as NSCLC. Okay. So these two would be wrong here. This would take the discussion for the slide into that zone. What does WHO recommend? Why did you say favor without doing IHC, right? If you say either malignant mesothelioma or NSCLC, I would expect you to defend yourself why you were able to rule out the other one, right? On what morphological clues did you use? Best would be this one, right? Differential diagnosis of mesothelioma and non-small cell and give me the appropriate IHC panel to work up further. Okay. Again, if you say poorly differentiated carcinoma, once you use the word carcinoma, you have ruled out mesothelioma, right? That again doesn't seem justified in this case to me. Morphologically, it's very tough to differentiate this malignant mesothelial proliferation from non-small cell. And we haven't ourselves seen any mucin, we haven't seen any glands, we haven't seen any keratin. So it's really tough there. So this seems to be the most appropriate way to go forward, right? Any questions here? Okay. If any questions you can type here, we can come back to it later if you're still keen on doing that. And this one is a spotter. We can finish this very quickly. So this biopsy is from a trachea, and we are seeing some lining here. We are seeing a lot of this eosinophilic material here, right, which is coming in clumps. That's another high power of the same thing. There's some squamous metaplasia of the lining and a lot of these eosinophilic clumps here. What do you think this is? What would you like to do? I can show you another image. This is showing reactivity to some stain, which is appearing. Yeah, so that's the answer. So Rachita has got that. That's amyloid, right? So pale extracellular eosinophilic material, okay? And that's congruent stain, right? So here again, in the absence of congruent and this thing, again, here the features are straightforward. And this is the apple green birefringence, which you can see on polarization microscopy. So that was a case of amyloidosis. So exam, again, expect a spectrum of cases, right? Not everything neoplastic. You will get a set of neoplasias, you will get some reactive conditions, you will get some infections, you will get some cases where you need to do some kind of scoring system, right? Liver, for example. You may get a kidney biopsy depending on whether your center does enough kidney biopsies, right, for you to be evaluated. So expect a spectrum of cases, not just malignancies. Okay. And this one, this case, a patient has is a 76-year-old male. There is cough and shortness of breath with obstructive jaundice. All right, and there is peripheral ground glass opacities with bronchiectasis. On radiology, they thought it could be organizing pneumonia or a tuberculosis. Okay, and they did a transbronchial lung biopsy. And the findings here are quite straightforward. So what we can see here is all these alveolar spaces, right? And something standing out oddly in between, right? Interspersed in between. What do they appear like to you on this par? More of it here, right? Again, same alveolar tissue. We are seeing a lot of these alveolar outlines being maintained, but the lining getting replaced, okay? They are glands. What type of glands? The lining epithelium seems to be. Okay, there's a lot of eosinophilic columnar cytoplasm there. The nuclei are all basally located. There is some material there, columnar. Honeycombing is a good differential. Okay. We'll discuss that. So Preeti says it could be honeycombing. So what do you mean by honeycombing, Preeti? Type it out. I'm glad you brought it up here. So columnar lining we can see here, right? And they are all still limited to the alveolar spaces only. This is a higher power of the same. Right. So Siom says it's a mucinous carcinoma. Preeti thinks, yeah, Preeti, you have answered that question, right? So honeycombing, metaplasia, you are saying these are metaplastic glands lining the alveoli. So what kind of lining do you expect to see in those metaplastic linings? Somebody said papillary pattern. Ayushi says adenocarcinoma. Okay. Okay, so for Preeti, if you want to diagnose this as honeycombing, right? The other word for it is peribronchial metaplasia, right? The Lambertosis. What kind of lining do you expect here? I would expect to see ciliated columnar epithelium, right? In this, there are no cilia. All I can see is this columnar epithelium and a mucinous lining. Correct. So Payal has got out the word I was looking for. It is having a lepidic pattern, right? So all of you who are answering adenocarcinoma so far, pay attention to that pattern, right? Because that pattern needs to come in your bottom line diagnosis, right? That is important here. Again, if this is not sounding very familiar to you, you need to go back and read the WHO chapter on how do you report lung tumor biopsies, right? There are 3 tables. You have to have that tables on the tip of your mind, right? So WHO recommends in this scenario with this morphology on a biopsy, what is the recommended terminology you need to use, right? There are a different set of terminologies we can use on a biopsy, different set of terminologies we can use on a resection where we are able to see a lot of other patterns and infiltration and everything. Okay, what can you report with IHC? What can you report without IHC? Right. So these set of cases highlights that, and I expect for an exam going PG to have internalized these enough to reflexively answer these things. Right. So you should not miss out lipidic pattern here. Right. So those bottom lines should be in line with what the WHO has recommended for a common tumor and a common biopsies which we've been seeing. Okay. So here anyway. Notice that everywhere we are seeing that this lining is limited to the alveolar outline only. That is the interstitium, right? No place are these tumor cells going and infiltrating the interstitium, all right? So in this case with this morphology, what would you write as the impression or diagnosis? So a lot of your discussion would depend on what you write here now, because finding wise, you should lipidic pattern. I would expect you to tell. I would expect you to have searched for foci of invasion here and specifically mentioned that I didn't find any invasion in the interstitium here. Okay. So, okay, you call it adenocarcinoma, predominant pattern lipidic. Some of you are answering D. Adenocarcinoma with lipidic, differentials include 1, 2, 3. Savita says E. Okay. So you're in the right zone, but so far I've got only one correct answer, right? As per WHO recommendation, this has to be called as mucinous adenocarcinoma with a lipidic pattern. Okay. So lipidic pattern, again, if it's earlier, these things used to be called as bronchoalveolar, right? So bronchoalveolar carcinoma. So there again, there are two types. One is a mucinous type, other is the non-mucinous type. So here it is clearly mucinous we are seeing, right? So you use the terminology where mucinous adenocarcinoma is being brought into the picture. Otherwise, this adenocarcinoma with lipidic pattern refers to the non-mucinous types, right? So that distinction, if you remember, CD versus E, you can remember easily, right? So in the WHO table also, if you go and look at it, if you are able to find mucinous columnar cells in the lipidic pattern, the differentials will include at least 3 entities. One is this minimally invasive mucinous adenocarcinoma. It could be a mucinous adenocarcinoma itself, right? Metastasis also comes into the picture. Okay. So those differentials need to be listed here. All right. So D, E, E, yeah, we haven't got any A, Bs and F and Gs, so that's very good. And again, NSCLC favor adenocarcinoma. There is no need to use this kind of terminology because we are clearly seeing mucinous lining here. There is no possibility that this is a squamous lesion, right? And just reporting it as non-small cell carcinoma would be very under-reporting it, right? We are clearly seeing mucinous differentiation. We are clearly seeing glandular differentiation. We are clearly seeing lipidic pattern, right? So this is where it would come. Okay. For exam, at least I would missing out lipidic pattern would be would be bad, right? Basically, because lipidic pattern is very clear here, right? If you call it as adenocarcinoma with lipidic pattern, it's acceptable, right? Exam, you have missed out this, acceptable, right? But these things would be wrong. Then the last case. Okay, any questions on this one? So lung tumors, just go back to that WHO tables and make sure you internalize those recommendations very well. Okay, keep using that in your routine reporting to test yourself, right? It really helps you in exam. And these things, if you don't do in your routine reporting regularly, it's very difficult to get it correct in the exam, especially in the exam tension when you are dealing with limited time, right? So it's important you focus on these in your routine reportings.
So I think we can move on to the next case.
Yeah. So, and this is the last one. I can see it's already 9:49. So we'll finish, I promise, in the next 5 minutes. So last one, this is a right ovarian mass with peritoneal tumor deposits. Hysterectomy with bilateral salpingo-oophorectomy, omentectomy, and appendicectomy is done. All right. So we have 3 sets of slides. So this one is from the appendix. Okay. Appendiceal wall. We can see this epithelium, lot of mucin in the lumen. All right. We can see some inflammation. Again, the glands, the lymphoid aggregates are normal there. Here we can see some amount of edema, right? Some fresh fibrosis, some calcific foci, lot of mucin in the lumen. Okay. So that's the appendiceal lesion. A higher power. Again, basally oriented, some pseudostratification is there, right? But not very pleomorphic, not very atypical appearing nuclei. There are no mucin pools with floating cells in the appendix at least. Okay. This one is the left ovary, lot of preserved ovarian parenchyma, but we are getting these pools of mucin with this lining epithelium here. Okay. Higher power atypical cells, okay, which are piling on top of each other, which are forming these strands. Okay. That's the left ovary. This is the right ovary. So we are seeing large cystic spaces filled with mucin, lined by the single layer of mucinous cells. There is dissecting mucin in between, right? Devoid of any lining epithelium there, which is containing this floating signet ring type of cells here. You can see that, right? And there are floating epithelial sheets also, epithelial strips within this mucin pool. Right, same thing. This is a higher power of the signet ring cells which are floating within mucin, atypical looking nuclei. All right. So yeah, with this much we are beginning to get some answers. Ranchita says LAMN in the appendix. I agree. And she also says mucinous cystadenoma. Preeti says it's Krukenberg, and that is exactly the point of this case, right? We want to discuss what will you take as primary here. Right. So Rachita, do you mean to say you are saying LAMN and mucinous cystadenoma? Do you mean they are two different entities? Right. The patient has two different lesions here, primaries. And Preeti, if you're saying Krukenberg, can you tell me what would you state this tumor as? What is the primary and what would be your bottom line diagnosis? Okay, so some IHCs are coming up, CK20, CDX2, there is a wider panel. And what is LAMB? Okay, I think you meant to type LAMN. All right, LAMN is correct. The appendiceal lesion is low-grade appendiceal mucinous neoplasm. I completely agree. The issue here is you should be aware of this. This is again a very common scenario, right? Ovarian mucinous neoplasm as a broad topic. You should know what are the features which help you to decide whether the ovarian tumor is primary. What are the features which help you decide whether the mucinous tumor is a metastasis to the ovary? Okay. So here, correct. Preeti says the appendix is considered the primary in this case, and there is anyway pseudomyxoma peritoniae that we have seen, right? There are a lot of widespread peritoneal deposits. But here, what is the impression of the diagnosis? Which is the best suited among these 6 options? So D, we got one E. Mucinous adenocarcinoma with mets to bilateral ovaries. Okay, Daisy also thinks it is a mucinous adenocarcinoma. Okay. So far, see, mucinous adenocarcinoma, again, in the appendix also, you need to see all that mucin pool dissecting through the wall, right? The floating cells within the mucin pool. That is when you would call something as a mucinous adenocarcinoma, right? In the appendix, we didn't see any of that. We just saw that the lining was there, which was mucinous, which was showing a low-grade dysplasia. And there was surrounding a little bit of calcification and fibrosis and inflammation, right? Indicating that there is some level of infiltration limited to the mucosa and the submucosa. All right. So appendix, it is still low-grade appendiceal mucinous neoplasms. And this behavior is rare in LAMN, but it is known to occur, right? Especially if it is limited to submucosa and mucosa. So in this kind of scenario, we have to look, take serial sections of the appendix, process more of the appendix and see how deep